This is Dr. Brian Edwards dictating a presentation on the Tubby theory. What has changed from 2009 to 2014? The new guidelines came out, and as I predicted in my book, the non-HDL cholesterol would be the new metric. I called this non-HDL cholesterol a Tubby factor, as that was a lot easier to say and understand for patients. 4/5 of patients with metabolic syndrome are Tubby. These people have insulin resistance, and their LDL-C is discordantly low, while the HDL cholesterol is more accurate. My book also pushed for early treatment of subclinical plaque with low-dose statin and niacin. The guidelines advise 10 milligrams Atorvastatin for a risk of 7.5% after discussing with physician. The guidelines also advised using CAC or calcium score to reclassify risk to help make decisions. My book advised CAC in patients with at least one risk factor, and if subclinical plaque was present, then start low-dose statin and add over-the-counter niacin a month later. The risk guidelines in a Twitter from Dr. Neil Stone say that if risk decision uncertain, physician and patient can consider 1. Family history of premature cardiovascular disease, 2. Abnormal high sensitivity CRP or C-reactive protein, 3. Coronary artery calcium score, or 4. arterial studies to make an informed risk decision of whether to use statins or not. In my practice, I did not find CRP very helpful. I found arterial studies even less helpful. Since 2009, MESA trial designated calcium score and CIMT as independent and separate risk factors. This is important as it shows that these are valid markers of risk. Because calcium scores are often false negative, I found that CIMT should be done with a calcium score. Combination therapy is not strongly advised by the new guidelines because there are no good random controlled trials for this. However, I advise using the lowest dose of Atorvastatin or Simvastatin and then check the non-HDL cholesterol in 1 month. If the non-HDL cholesterol is not 80 or less, I then add on a wax matrix niacin, 1,000 milligrams, and check again in a month. This approach of using low doses avoids side effects, especially if starting treatment earlier in life now. The NLA, or National Lipid Association, formed a draft in April 2014 in Orlando. The reason for this was that the guidelines used mostly random controlled trials, which was good because this strict criteria strengthened the recommendation to start treatment earlier. However, the NLA wants to make sure that we do a more personal approach rather than an epidemiological approach. And this allows us to rely on less strict criteria of evidence. The main problem with the Tubby theory is its strong dependence on niacin in combination therapy, and there have been 2 studies since I wrote the book that seem to negate the effect of niacin, the HPS Thrive and the AIM High. However, these studies only showed that increasing HDL size with niacin did not have any benefit. However, the real reason I use niacin is to lower the ApoB, or particle number, or non-HDL cholesterol. And I use this because the COMPEL trial showed that by using a low-dose niacin of 1,000 milligrams, the non-HDL cholesterol, or LDL-C, would go down by 12%, while doubling the statin would only reduce it by 6%. So rather than use a higher dose statin with possible side effects, I would rather add a second drug at a low dose and use 2 low dose drugs, especially if we are going to treat lifelong to prevent the disease from occurring. One of the best validations of my theory since 2009 has been National Cardiologist Dr. Seth Baum making a video in March 2014. His video discusses the critical preventive tools and approaches needed to lower cardiovascular risk. For me, this scientific presentation is very similar to my presentation for the average individual in my 2010 video. In summary, the Tubby theory update is: number 1, non-HDL cholesterol is new standard. Number 2, calcium score advised to help decision making. Number 3, National Cardiologist urges similar approach. Number 4, 2 negative niacin trials don't invalidate using niacin to lower LDL particles or ApoB. Number 5, start with Atorvastatin 10 milligrams or Simvastatin 20. For further reading, please look at this slide. Thank you.